Welcome to EASL Studio, your weekly hepatology broadcast news. My name is Thomas Berg. I'm a hepatologist from University of Leipzig. And in our today's episode, we want to discuss what is hot in viral hepatitis in 2024. Well, you are well aware that we have effective vaccines for hepatitis B and hepatitis A, effective treatment for B and C, but still viral hepatitis is a major cause of liver-related morbidity and mortality worldwide. So certainly many things we need to discuss. And in our today's episode, we want to mainly focus really on vaccination strategies in hepatitis E and what is new in hepatitis E, but also C and with the CHIMP project. And you will hear about soon what a CHIMP project will mean. And there's a new WHO guideline for hepatitis B. And I think it's a very, perhaps in some ways also a provocative one, because some of the indications and recommendations really differ from what is written in the guidelines from EASL and ASLD. So also there are a lot of topics to discuss. And I want to do this together with the best expert panel you can imagine. So first we have Professor Norah Terrault. She's past president of ASLD and chief of gastroenterology and hepatology at Keck Medical Center University of Southern California. We have Professor Heiner Wedemeyer. He's also past EASL secretary some years ago, but still. And he's the chief of gastroenterology, hepatology, infectious diseases, and endocrinology at the medical school Hanover. And last but not least, Professor Jordan Feld, and he's professor of medicine and the interim director of Toronto Center for Liver Disease, and he holds the chair in translational liver disease research, University of Toronto. So a warm welcome to all of you.
Great to be here.
Thanks. Wonderful. So as mentioned, I think we can start perhaps really with hepatitis E virus infection. And at least in Europe, it's really the most common cause of acute viral hepatitis we see in our countries. But I'm not so sure about the situation in US and Canada. And perhaps, Norah, you may want to start with what is the situation of hepatitis E virus infection in US? What do you hear from your country, from your region?
What do I hear? I would say that, well, if we look at the frequency with which they're detecting antibody in the population, certainly the US is less than other parts of the world, in particular Europe, parts of Asia. So it appears that we have less exposure to hepatitis E in the United States than in other countries. And certainly clinically, it's not a frequently identified cause for acute hepatitis. Certainly not in my experience. We frequently test for it because we are recognizing this as a kind of a zoonotic infection now, as well as, individuals who are traveling and may have acquired it elsewhere, but infrequently see it as a cause for acute hepatitis, at least in the United States. My own experience is primarily with it as a chronic disease in a transplant population. That might be slightly biased because I'm a transplant hepatologist, but that's been my experience. I'm not sure, Jordan, if it's different in Canada, whether you're seeing something different, but certainly in the US, not very common.
Yeah. So how's the situation in Canada, John?
Well, we've had a pretty similar situation to the US, where we do see a little bit more seropositivity in areas where there's a lot of pork exposure. So we do see that in the farm country, and that's been shown in the US as well, that in the Midwest of the US, you see higher IgG prevalence. But in terms of acute hepatitis, we spend a lot of time looking, like Norah said, and a lot of negative Hep E testing. So certainly not as common here as it is in Europe and elsewhere.
Yeah, because Norah and John, you also mentioned the chronic infection. What is the average gap, let's say, when a chronic Hep E is detected, when you look back and there were already elevated ALT level or GGT levels, or is it normally you do it so regularly that you detect Hep E quite early on, chronic Hep E infection, I mean?
Well, no, and we don't routinely look for it. It's really in the setting of somebody who has elevated liver enzymes, and the other virological tests for other viruses we see post-transplant are negative, then we think of E, and that's usually the setting in which we test. So it's at variable times post-transplant. We're I'm not sure, we're not really confident about when they acquired it or when they became positive, because we are only testing if they become abnormal.
Okay.
So we haven't done that sort of detailed look. There was some earlier work, I think, looked at pre-transplant versus post, and didn't show that it's really sort of not a reactivation. It's more that we're seeing that they're acquiring hepatitis E in the post-transplant phase, but unclear when they're acquiring it.
Yeah. And Heiner, how's the situation in Germany or in Europe?
Yeah, obviously 15 years ago, we thought when there was a first New England Journal paper from Toulouse of these 14 cases of acute HEV in transplant populations and 8 became chronic, my first impression was, well, this does not exist. We are here in Hanover Transplant Center. I have never seen this. This may develop in southern France, but not in Central Europe. And we were wrong. It's a quite in the transplant building you find these cases. It's not 10-20%. It's 2-3-4%. But overall, it's a significant number where you find the chronic ones. That's I think in the heads of all, let's say, physicians here at this hospital. But my question to all of you, and maybe Thomas, you may also comment, is my biggest concern is not so much chronic hepatitis E in transplant recipients. I'm afraid that we may oversee cases of acute or chronic liver failure in a patient with fatty liver disease, with cirrhosis, alcoholic cirrhosis. They present with ACLF, and we never looked previously until a couple of years ago for hepatitis E as a cause. And we just lost a patient last week who in the end had met ALD, took some time. Finally, after months, he was transplanted. But the reason why he needed transplant was because of hepatitis E virus infection. And I don't know whether we are simply overlooking something.
It could well be. And do you see normally very high ALT levels, so that give you already a hint that there might be an acute viral hepatitis infection as a trigger for ACLF? At least in my experience, it can be quite moderate, so it's really easy to overlook it if you do not really regular test it.
I absolutely agree. It does not need to be the ALT of 800 or 900. You may have a patient with 150, 200 ALT, and then, yes, it may be ash or alcohol, etc. That's actually my biggest concern. And when we will talk about vaccine, these would be the group, the target group for a vaccine. But that'll be the next topic. Maybe the others first.
Yeah, but Jordan and Norah, do you test for Hep E in patients with ACLF? So according to the guidelines, we should look for triggers, right? And Hep B is mentioned, C is mentioned, of course, other also bacterial infection. But do you also look for Hep E?
My sense is not
systematically.
So perhaps Jordan first.
Same thing, is that not systematically. I think we probably aren't looking as often as perhaps we should be looking, and that's, I think, maybe speaks to the bias that we both mentioned, that we don't see it as often. Are we not seeing it because we're not looking? I don't think that's totally true, because we're really not seeing it very often, even when we do look, but perhaps we should be looking a bit more often. And I think Heiner's point about it not being the dramatic rip-roaring hepatitis with transaminases in the thousands is a flag that we need to look probably a bit more frequently, but at least in our experience, it's not part of our routine algorithm for ACLF. And I guess one question I would ask is, when in this setting of thinking about it in the acute setting as opposed to chronic, are you looking for viremia or for fecal shedding?
So we are looking for the virus itself, because obviously our seroprevalence in northern Germany is between 20 and 30%. The older, the higher, and the antibody IgG doesn't help you anything. IgM, you may have, in particular in patients with ACLF, a variety of IgM reactivities also to other pathogens. So we look for RNA.
But in the blood or the stool? Sorry, that's what I was.
We start with blood. That's what we have. If you have concerns in the long term, when we talk about treatment response, etc., they're still shedding, then you look from time to stool. But if we screen in blood.
Yeah. Norah, do you want to comment or?
No, I would just add that I think it's infrequent that we look for it as an ACLF kind of presentation. I think in somebody who's got elevated transaminase, not into the 600 range, but even if they're into the 100 range, we would do other viruses. And I I think you make a good point that hepatitis E probably has to be added to the list.
Yeah.
But we haven't been doing it systematically. It's a good
I
You
point.
may
would
ask-
highlight, we did do a study in the Hepatitis B Research Network, Norah will remember this, looking for whether hepatitis E was causing flares in this population of people with chronic hepatitis B, and we didn't find any. So not to mean that, again, it's not there, but we didn't find it in the setting of those flares. So at least it may speak to different epidemiology in North America versus other parts of the world.
Yeah, and of course, you may also question what are the clinical implications? So, Heiner, do you treat then with ribavirin in this situation if the patients are still high viremic?
Yeah, I think that's an area of research that is needed. Is ribavirin effective in treating ACLF patients with acute hepatitis E, or do we harm patients if you have anemia, if you have some kidney problems? And when we have the round in the morning in this hospital here, and then we fight with each other. So we have, let's say, 50% of the people, yes, there's a virus. We have a drug that may reduce viral load. We have to treat him with riba. And the other, show me the evidence that you really save a single patient. What is there? We need a research. We need a study on ribavirin and ACLF caused by HEV. Yes, number is small, but the evidence is limited. Quite frankly, if the kidney function is fine, if they have an hemoglobin level above 10, I try a small dose of ribavirin in these patients, but some of my colleagues do not.
So this is clearly hot, and this may speak for a joint, I don't know, European Horizon Europe, or a global attempt really to study this. I fully agree. And we only need short-term treatment to do something. So perhaps it's really something worth studying. But another approach would be prevention. And we are really also here to discuss a quite recent paper. It was published in The Lancet from China, really a long-term study of hepatitis E vaccination. And to introduce perhaps this paper, we also ask our audience, we sent out on X the question, is there a need for hepatitis E vaccine, and is it time to implement one? And there were 30% roundabout us telling us yes, and another 60% saying yes, but targeted towards at-risk groups, and only 9% were not in favor, or they feel that a vaccine is not needed. So what about this paper in Lancet, Heiner?
Yeah, indeed. This is, I think it's a landmark paper. For those of you who missed it, it was published early March in The Lancet, and it's the third paper in a high-ranked journal out of the study. So the initial, it's a long-term follow-up, 10 years after vaccination. The initial study report was in The Lancet 10 years ago, 12 years ago. Then the follow-up, the first follow-up was published in the New England Journal of Medicine. Now we have this long-term follow-up, 10 years after vaccination. So what was it? It was a study involving more than 100,000, I think 112,000 subjects being vaccinated in the one-to-one randomization, and half of the patients received the active vaccine, which is a protein. It's called HEV239. And that the first important point is this vaccine is a protein, and it's based on HEV genotype 1, which is very important because in that region in China, usually genotype 4 is prevalent. And that's my first point. The second point is really that the aim of this vaccine was to prevent cases of severe acute hepatitis. And that was the end point. And the short-term message is, yes, this vaccine remained efficacy even after 10 years, which is really remarkable. So vaccine efficacy above 80%. But the numbers are small. We're talking about 112,000 individuals being included in this trial. When you look at the numbers who actually had a confirmed course of acute hepatitis, it was in the patients receiving the vaccine, it was 13 cases. And in the placebo group, the number was higher with 80 or 90 cases in that case, or 77 cases in the placebo group. So you need to vaccinate 100,000 individuals, and in the end, you have these small numbers of cases. But it's important to highlight that this vaccine, the aim was not to induce sterilizing immunity to prevent any infection. the aim was to prevent symptomatic hepatitis, which was the endpoint. And by the way, Jordan, when you mentioned that in hepatitis B in your network, you didn't find HEV as the cause for these ALT flares, the workup in that trial was they looked for confirmed, or they had hepatitis cases with elevated ALT levels in that 10-year period. I think they had 12,000 events of ALT increases overall, and the cause was hepatitis E in less than 100 overall. So this shows you that you need to screen many patients with hepatitis to identify these E cases, even in that region. But I think the most important point, Thomas, is the vaccine efficacy, and that the patients received 3 vaccines, baseline, month 1 and 6, and that this was a long-term efficacy, which I think is remarkable. The vaccine really works. It prevented cases of severe acute hepatitis in these patients with a simple protein-based vaccine, Thomas.
Vaccine, yeah. No, absolutely. And thank you so much for highlighting the most important findings. So Norah, and then perhaps Jordan, do you have any comments about it? What was your take from this landmark study?
Well, I think my take is that it's very applicable to areas of the world where they get, outbreaks of hepatitis E, and where there's large numbers of individuals potentially at risk. And where, in particular, with that genotype, their genotype's association with the kind of high rate of mortality in pregnant women, right? So that's the setting in which prevention of severe infection is most important. So I see this as like a really critical study for the population in which it's currently being used. Does that translate into, say, North America, where we don't get outbreaks of hepatitis E? We have a zoonotic disease largely. And so we are much more into an at-risk population potentially. So whether those results are at all applicable is, I think, something quite questionable. But for the population that is really in need of a hepatitis E vaccine, like China and parts of the world where they get huge outbreaks and so many at risk, so many die, it's a remarkable study.
Yeah, and Jordan?
And I think I would pick up on that exactly and say this is a vaccine that you can implement in a setting. It's fairly quick. And actually, there was some nice discussion in the paper where they talked about using a 2-dose version of the vaccine as well, and at least getting short-term high levels of immunity, which is particularly attractive, as they tried to do in this outbreak in South Sudan recently. And I think thinking about it in that setting where you've got a very high population at risk with a ongoing epidemic, where if you can implement, and we learned from COVID-19 that you can implement fairly rapid vaccination, that you could potentially stem the tide of an epidemic. And I would really focus on the point that Norah made about preventing this in pregnant women. So really targeting that population, because although I think Heiner's point about ACLF is a really interesting one, obviously this study didn't really evaluate the immunogenicity or response rate in people with chronic liver disease, and particularly cirrhosis, where we know vaccine responses are less robust, and also the degree of hepatitis that tips them into ACLF is probably doesn't need to be quite as severe. So I would probably think about it in that setting, and it's probably less relevant for the genotype 3 infections that we're seeing from swine.
Yeah, I think these are very important remarks. And it also, with the different genotypes, and perhaps to you, Heiner, Hep E is quite common in Germany or in Western Europe, let's say, but we normally do not see any liver failure or these very severe infection in pregnant women, right? And perhaps this is really related to genotype 1. So would you agree that perhaps the vaccine for pregnant women, or before, or in a broader context, would be really something more for those countries where the more aggressive virus is endemic?
Yeah, absolutely. Norah made the point. I think when we're 10 or 12 years ago, the outbreaks in the refugee camps in South Sudan, for example, there the vaccine was used, and it really helped at that time. And therefore, that's the setting. And I agree with Jordan. So in Germany, we have, Thomas, almost 1 million people with liver cirrhosis. And the question would be, would these be all candidates for an HEV vaccine to prevent some cases of ACLS? This is the question. I think If we would have a good vaccine, probably yes, to prevent their severe cases. But the question is this vaccine effective also against HEV genotype 3 to prevent symptomatic cases? Probably yes, because the HEV genotype 1 vaccine prevented genotype 4 symptomatic cases. I don't think it will be sterilizing. That's the point. So in an ideal setting for Germany, I want to have a simple vaccine, ideally based on genotype 3, which I can use for high-risk patients, where also immunogenicity in some people with slightly impaired immunity, that this would work. That would be my dream, but we are far away.
So this means that before going and asking for vaccination of, let's say, patients with cirrhosis, we should do perhaps more epidemiological data on really the risk for these patients in different regions, countries, as a trigger, let's say, for ACLF or morbidity, mortality.
And what we may need for ACLF and also for chronics, we need antivirals. We talked about ribavirin as the only option, but I want to have an easy, safe, direct antiviral, which I can use in these ACLF patients or my post-transplant patients to cure it. I think there's really a need for antivirals in this term, ideally a vaccine in the long term, but we've discussed limitations. I need an antiviral.
No, I think that's really very important. And I want to complicate the issue even a bit more, but perhaps this is the last point I want to raise with hepatitis E to make things even more complicated. And this is a recent development or finding that also a rat hepatitis E virus, although a completely different species, can infect humans. It was first shown in 2018 in Hong Kong with a few cases, but now we have new data on HIV co-infected patients in Spain showing that at least 1% of all acute viral hepatitis cases are related to a rat hepatitis E. But we can't test them with our current tests, right? So is it something we should be concerned of? Do you think it could be really explain the unexplained cases we always see with an acute hepatitis? And should we not go really for testing and implementing also rat PCRs, rat Hep E RNA PCR tests? I don't know, Norah, do you want to start?
So, I have to say that, I think our experience with COVID kind of shapes our thinking about emerging pathogens a little bit differently than it did a decade ago. So I think that that's why the news around this rat to human, virus is really, I think, grabbed more attention. But again, I think we need to understand that epidemiology. We need to have a better understanding of really how frequent it is. But as you highlight, that means we've got to develop the test to be able to do that. So I guess my take on is it warrants more study. But I would say, this idea of human diseases, emerging from, as new zoonotic infections is now reality. So I think we are certainly more in tune with being attentive to them and being thoughtful about developing the test to be able to evaluate them further.
Yeah, Jordan, your comment on that?
I would echo that. Really, we need more data on this, but probably there's been the long look for the non-viral hepatitis, non-ADE viral hepatitis, and many sort of false claims of finding it. And it probably is a mix. It's not going to be one virus that accounts for all of those infections. But I do think that we should probably, and there are a number of programs ongoing of viral discovery programs of looking. And I would really just say for people, when you see these acute hepatitis episodes where you don't have an explanation, is storing blood so that whether it's this particular virus or it turns out to be some other new pathogen, we're able to discover them, because the viral discovery networks now are much better.
Yeah. And Heiner, your comment on that?
Nothing much to add. Let's say we have to look for this. We have to generate the data. I don't think that will be the drama that rat HEV is the threat for all of us, but we will find cases. I'm sure we will find cases, and then again, the patient suffering from a disease doesn't care if this disease is frequent or rare. They want to have an answer. So we even have to for rare cases, we have to identify this. We have to do our homework. and everybody's starting now screening efforts. So we will see more cases. That's
Yeah.
great.
No, I think this is really very important. And I think it's really also important to be aware that this may happen. And these cases have been found in large studies. And perhaps what Jordan also mentioned, at least to collect a sample that we can do testing on a broader scale later on could be really help to better understand what is needed here. I think we can now move forward to the big issue of effective vaccines and vaccination in hepatitis C virus infection. And we also asked beforehand our audience 2 questions, and I would like to read these questions. So the first one was, can HIV infection be eradicated solely through treatment, or is a vaccine necessary? And it was really a 50-50. So yes was 50% through enforced DAA treatment approaches. So you can perhaps do it just by having a better approach to who to treat with DAAs, or the 50% where no eradication requires a vaccine. And the second question was, do you foresee the development of an effective HCV vaccine? And here the people were quite optimistic. 60% said yes, and 40% said no. And we have Jordan with us, and he is very much interested and also to find new ways of hepatitis C vaccination. So perhaps, Jordan, you can update us what has been done so far, and what do we understand about this CHIM model that was also recently published in the New England. Yeah.
So I think there's a lot of interest in developing a hepatitis C vaccine. I think when the DAAs first became available, people hoped we wouldn't need a vaccine. Although that would be nice to see, it's really disheartening to see that if you look around the world, every year in the last few years, we've seen more new infections than cures. And that's really striking in North America, where we have the ongoing opioid epidemic. But even in many low and middle income countries, access to DAAs is limited, ongoing transmission continues to happen. And unfortunately, the injection drug use has actually spread to many middle income countries as well. This is spreading across Asia to some degree. And so I'm not optimistic that in the absence of a vaccine, we could really achieve eradication, and maybe even in some places not even achieve the elimination goals, which is really more about control. So I do think a vaccine is certainly desirable, if not absolutely necessary. And then the question of how to do it. So there's a few obstacles here. One is that this is an incredibly diverse pathogen, so the immunology is tough. The vaccine that worked for hepatitis E is not going to work for hepatitis C. A simple protein vaccine for conserved epitopes is not going to work. So it's going to have to be more it's going to be more complicated to develop the vaccine. And then I think the real challenge, which introduces this concept of a challenge model, is how do you even test a vaccine if you've got a good candidate? Because there was this very heroic effort done by Andrea Cox and Kim Page in the US to lead this NIH study to evaluate a hepatitis C vaccine. This was a sort of similar vaccine to the AstraZeneca Oxford COVID vaccine. So it was a prime boost vaccine using a chimp adenovirus. And it looked promising in chimp studies, in preclinical data. And then unfortunately, after a 10-year marathon, basically 6 years of study, about 3 to 4 years preparing for it, enrolling over 550 people, they showed that this vaccine was not effective at preventing acute or chronic hepatitis C infection. And it was a difficult study to do among people who inject drugs that were seronegative for hep C at baseline. So this is really not a very challenging population study. So this raised the question of, could we actually think about a challenge model where we take the fact that DAAs are so incredibly effective, could we intentionally infect people with hepatitis C and then use that as a model to test vaccines? And this obviously raises many questions about the ethics, about how to do it, what are the goals of the vaccine to do that. But I would highlight some advantages to this approach, that in that huge effort that they undertook to test the initial vaccine, they saw about 35 acute infections in both groups and 14 chronic infections in both groups over a 6-year prospective study. With a challenge model, we could get that number of infections because everyone gets infected that you challenge with the virus, you could do that very quickly. So it really gives you a platform to be able to study this much more robustly and efficiently. And I think one important point about that is two things, is that it encourages people that are developing vaccines to develop vaccines. If you have no pathway to test your vaccine, no one's very interested in making a vaccine. And secondly, what we will learn from the challenge model by these observed infections where we know the inoculum, it's very well characterized, and we can, in a very detailed way, follow the immunology as people to really understand what is the correlates of protective immunity, even if the first vaccine candidates studied in a challenge model are not effective. Hopefully what we will learn from the challenge model will inform vaccine design so that subsequent candidates will be more effective.
Yeah, no, this really sounds quite interesting. So CHIM means controlled human infection. And may I ask you, how far are you with your group? Is there already, I don't know, a study design or already a vaccine that you can use?
Yeah, so we're fairly far along in getting this going, and this is a collaboration with a number of sites across North America. And I would say there's a group in North America working on this, which I'm involved in to develop a controlled human infection model. And then Ellie Barnes at Oxford University is also leading a group with a number of European investigators to also develop a controlled human infection model. And we're working very closely together to make sure these are complementary, doing it slightly differently. We're going to try to use an acute inoculum. So the way we will do this is take someone with chronic infection, infect a single person, and then that single person will provide plasmapheresis samples so that we have a huge number of doses that we can then use for all the future infections. And the advantage to that is this is highly, highly infectious during the hyperacute phase before antibody seroconversion. So you need a tiny inoculum, which gives us enough virus to infect everybody for future CHIM studies. We'll do this from a few different genotypes so that we have some variability. And then you also have a very defined inoculum, so you can really compare one to the other.
Do you have any idea when it could be first in human, or is it too difficult to say?
So we've worked with regulatory authorities in Canada, and we have very positive signals. So hopefully later this year or early next would be for that first infection to generate the inoculum. So it's coming along. It's not quite there, and we're working through the hurdles. And Ellie's doing it with a chronic inoculum, where she will use just a chronic donor and infect a single person.
Yeah, so thank you so much, Jordan, for really highlighting this important project. I think many people outside would say, well, this is really tough to do. And what the community is thinking, what our patients thinking, and are there any concerns, also that a very short-term infection may have consequences? So Norah, when you first heard about it, what was your feeling, or do you really also see it in a similar way that we will never get really a vaccine if we do not do it like this? Because it's the challenge of the vaccine is one thing, but really to find the target population, all these issues Jordan mentioned.
Well, I have to say, when I first heard it, I was like, oh my God, really? Seriously, that's what I thought. But I have to say, what really changed it for me was I was part of a webinar where I listened to individuals who've participated in other human infection studies, not with Hep C, but with other pathogens, and just hearing their perspective in terms of how they're contributing to science and why they find it high value to be participants, and that there are individuals that are very motivated to do that. So that kind of changed things for me in terms of just thinking about it. But I think Jordan has very nicely highlighted that I think our ability to get to an approved vaccine without this model is really limited, right? Because it's too long, the studies, they're too enormous, and it's going to discourage vaccine developers. And I think it's obviously we need them now, right? We're all trying to move towards elimination. The need for the vaccine is real. I completely agree that I think we can't get to where we want to go without the help of a vaccine, particularly in the populations at high risk for new infections. So for all those reasons, I'm excited that this is an option that we can consider. I think there's still a lot of things to be very thoughtful about and careful, but I think there are individuals who are very motivated to be participants in such studies. I think we have great DAAs. We know a lot about kind of how to monitor patients, how to intervene, and it really will advance the science. So for all those reasons, I'm an enthusiast now.
No, thank you very much, Norah. And Heiner, perhaps more specifically, when would you start with treating these patients? Because we know that sometimes also an acute infection, can have long-term consequences. We know from coronavirus, with brain fog and so on. So would you start immediately if the RNA is going up in order not to have a disease like this? Or do we want to also see whether the vaccine perhaps is not sterilizing, but helps for clinical infection?
This is obviously the most difficult question to be answered. And with Jordan, we had discussions for years. We just had 4 weeks ago a European meeting where Ellie Barnes, Jordan, was there. And Ellie is really the driving force of this model in the United Kingdom. And we had the same discussion. It's a lengthy discussion. But the point is and therefore, the key question is, what would we want to have from a vaccine? Classically, and Andreas' endpoint was prevent chronic infection. If this is your endpoint, what you want to achieve, you cannot start too early. But Jordan, I think we have to challenge our friends, the virologists and immunologists developing this vaccine. We should be more ambitious. I think with the fantastic developments in B-cell immunology and understanding the epitopes, confirmation, what is really neutralizing, super neutralizing, I think we can have vaccines that maybe even sterilizing or very early. And if this would be the point, then obviously starting treatment after 2 to 4 weeks may be possible. With the currently available concepts, it would probably be too early, because then you cannot answer the research question. And that's really the question. Thomas, you mentioned brain fog, long corona, we call it long hep C. We published also said, but on the other hand, we are exposed to so many viruses. Yes, there is a remaining risk that a challenged individual may develop some of these symptoms. We need to understand it. I think in the end, Jordan, I don't want to wait for 6 months before starting. I would like to do this between 1 month, mostly 3 months, but it depends on the vaccine. And we need to challenge the virologists to be more ambitious. That's by much. But I have to thank you guys. I think you're doing a fantastic job developing this one. We need an HCV vaccine. Vaccinology has really improved. We have much better vaccine ideas than 10 years ago. I'm 5 years ago, I said we will never have an HCV vaccine. Now I think we will have an HCV vaccine.
Yeah. So thank you so much. So perhaps a final comment from you, Jordan, before we move forward.
So I'm excited, and I think that you've highlighted some key issues here. We've spent a lot of time working with the community to make sure that if we do this, that they're on board, because I think that's critical. If we develop a vaccine and then people don't want to take it, that's not very useful. I think Heiner's hit the nail on the head of how long do we need to keep people infected. The one caution I would raise is that even a relatively ineffective vaccine might speed up clearance and give you the sense that it's more effective than it is. So you have to be a little careful about intervening too early. But I am cautiously optimistic that with the vaccine development and new strategies that we will be able to get to, I don't think quite a sterilizing vaccine, but a vaccine that leads to rapid clearance. So my guess is the CHIM experiments will shorten over time, and that's what I'm hopeful. Hopefully we'll have new updates for you by next EASL.
Excellent. Thank you so much, Ron. And I think to come to an end of our session, we come to a less complicated topic, and perhaps where we have more clinical data, and this is Hep B and the new WHO guideline. And so far, at least in the Western guidelines, we were a bit conservative in terms of treating Hep B, right? We need histology, advanced fibrosis, ALT, not only elevated, 2 times upper limit of normal to have a clear indication for treatment. And now there's a new HBV guideline, is more going in towards, and this was the question that I asked also the audience, should we treat all patients with chronic infection regardless of HBV DNA and ALT levels? So if HBs antigen is positive, we just go for treatment. And the answers from the audience was only 35% yes, and 65% no. But this means also a third of the community feels, well, we are perhaps really a bit too conservative. And I don't know, Norah, perhaps, do you want really to summarize what are the key novelties or recommendation in terms of treatment indication from the WHO, and in which way it changes or it's different from what we have in the AASLD or EASL guidelines?
Well, there's some consistency across all the guidelines, I would say. They, first of all, kind of identify that those that have cirrhosis or an advanced stage of fibrosis should be treated. That's pretty consistent across guidelines that we recommend that. They also recommended for individuals who have co-infection and delta and extrahepatic manifestations. That's consistent across all the guidelines. But where they differ is really they've eliminated e antigen. So most of our guidelines, have different recommendations for e antigen positive, e antigen negative. They've eliminated that. So now it's just based on ALT levels and HBV DNA levels. And basically they're recommending that if individuals have both an elevation of ALT, and they use 19 for females and 30 for males as the cutoff for normal. If it's above normal and their HBV DNA level is greater than 2,000, those individuals should be considered for treatment. So that's quite different from our guidelines, where we use, perhaps we use a different threshold for ALT. So some use 2 times upper limit of normal versus upper limit of normal, and where we use a different threshold for HBV DNA depending on e antigen status. Clearly, if you're going to eliminate e antigen as an additional test, which I think the WHO is going towards simplification, they're thinking global, then that strategy makes complete sense. I think, but that's the main change, is that they've moved to really just using ALT, HBV DNA. And if they have both those things that are elevated, that's an indication to treat. They also have a requirement that if you can't get HBV DNA levels, that even just an ALT elevation in somebody who's surface antigen positive could be an indication for treatment. So that's clearly a very different scenario, but they're being very thoughtful about resource constraints and operating in countries where access to HBV DNA or e antigen are really barriers to moving forward with treatment. So WHO has a different kind of, I think, view on who they're trying to get recommendations out to than, for example, what we have it in the US and perhaps what you have in Europe as well. So there's differences, but I think there's some core things that are quite consistent across all guidelines as well.
Completely agree. And in these countries, we quite often have the situation that testing for DNA, HBV DNA, could be more expensive than just treating. This was always raised as an argument to go towards this direction. So perhaps Heiner, and what do you think about this? And they also implemented this non-invasive fibrosis test. So if HBs antigen is positive, you do not have any chance for DNA testing. Also an EPRI score or something else could help you to guide treatment.
Yeah, I'm not sure whether we really need these fibrosis tests and to determine cutoffs whether tests start yes or no. Norah mentioned the most important points, I think, and you highlighted this again. If I don't have HBV DNA testing, then S antigen positive and ALT should trigger treatment. In particular, if treatment is available, because we are talking about drugs which are generic. We have decades of safety data that they really work. The risk to induce, let's say, 10 years ago, we were talking about resistance, monster resistance. It does not happen. So I think the risk, and even the last point is even stopping now, as you showed this, Thomas, with your trial, can be even a therapeutic approach. So the risk is quite low. We still have to identify, we should, in a setting that we don't overtreat patients, that we don't interrupt treatment. There may be flares in single cases, but overall, I think being a little more aggressive and not because of limitations to availability of testing to withhold treatment, this is unethical in my view.
Yeah, and John, I think AASLD and EASL have commissioned new guidelines for Hep B and to update it. How do you think will this WHO guideline influence the recommendation of the Western guidelines? And should we really get rid of these, ALT greater than 2, and you need the fibrosis 2 and the E and anti-E status, really to simplify the issue, as Norah mentioned?
I think it's an important question. I think Norah highlighted some key points that really we are targeting somewhat different audiences. And I think the WHO's perspective was that undertreatment continues to be a massive problem in low and middle income countries, where even in places where diagnosis is made, the proportion of people who get on treatment is very low, and the burden of HCC and advanced liver disease from HBV continues to be enormous. So they're really just looking at a strategy to say, perhaps instead of our default position being, well, if we're unsure, let's continue to monitor, making the default position to say, if we're uncertain, treat. And I think that certainly makes sense in many parts of the world. My guess is that EASL and AASLB will continue to still be a little bit more conservative, and at the very minimum collect data to really understand where treatment is more clearly indicated. But if I had to predict, I would say that there will be a bit of influence of the WHO guidance, and also, to their credit, the patient community, which has really advocated for more interaction and involvement in treatment decisions, so that there may be a bit more of a permissive approach to treatment, where instead of saying treatment is not indicated, we say where treatment is clearly indicated, and then areas where there's uncertainty, and that you may make a decision on an individual patient provider basis.
Yeah, so I take the message from all of you that you are not in favor of treating all patients only because of an HBs antigen positivity, right? You all agree on that. You're more on the 65% of the poll. So the last question to all of you, and perhaps a brief statement. When we come more to the Western countries where HBV DNA testing and so is not so much an issue, do you think we should be more proactive in implementing the newer biomarkers, whether it's correlated or HBV RNA, also in order to convince the industry really to provide robust tests, because it could really help to better define risk of progression and treatment indication? I don't know, would you like to start, Heiner, first, and then we go to Jordan and Norah?
I think a clear yes, Thomas. I think we have novel markers, and they give additional information on the biology of this infection, and we have to use them. They are associated with disease progression. We may use them to identify a patient where we can safely stop treatment. Yes, it's not the answer to everything. The available tests must be improved, HBV RNA testing, correlated antigen, and maybe other testing. So I think that we are not there yet, and therefore any additional marker may help us in the end in personalizing treatment of hepatitis B virus infection.
And Jordan?
These tools are really useful, and I think we're getting increasing data that they really do reflect what's going on in the liver. I would argue that there's still more for helping us understand how to cure hepatitis B and how the new drugs are working than how to guide clinical practice right now. So although personally I would like to see their availability, I'm not sure that they're actually adding that much to our current tools. And I would first of all say we don't even have good enough access to quantitative surface antigen globally. It's only very recently become somewhat available in the US, which is a problem. It is more available, fortunately, in Canada and Europe. But I would say make better use of the tools we have and use these tools more to guide research would be my bias for now.
Thanks, Jordan. And Norah?
Yeah, I think both Heiner and Jordan have kind of really set the stage. I think we definitely want to see them come forward, because I'm really looking ahead to the new therapies. And this is where I find I'm sort of at odds with the Terrault to some extent, because I actually think Hep B therapy is going to become more individualized, personalized, and probably a little bit more complex going forward. We're going to need these new virological tools to help us to do it well. But I really am looking toward the future where with new drugs, we're going to focus much more on functional cure. And really, it's going to be a much more personalized form of medicine for Hep B, probably for the first time in in decades, right? Rather than a sort of one drug for all, it's going to be really much more nuanced. I think that's our future. And for that, we're going to need those new tools, I think.
Wonderful statement. So thank you all so much for a wonderful discussion around what is new, what is hot in viral hepatitis. I think we could talked for hours, but unfortunately we have to come to an end. We're already a bit longer than we normally expect, but I think the topic was really worth it. So I want to conclude and to really highlight also next episodes. So this was the last episode of season 7, but the EASL Studio comes back next week, and this means live from EASL Congress. And our program there includes 12 exclusive episodes to be aired live from Milan and featuring 44 renowned experts. For those unable to attend the Congress, these episodes will be available live on easl.eu and on demand on EASL Campus. So thank you all for joining, and please be reminded to become an EASL member, and see you soon. Thanks a lot.
Bye.
Bye-bye.